now that we have PARP inhibitors approved for patients who have BRCA mutated metastatic disease, there's been a lot of interest in combinations of therapy with PARP inhibitors and checkpoint inhibitors. Priyanka, do you want to comment a little bit about the hypotheses behind combining these agents?
Sure. So, as you said, PARP inhibitors, we've had them available to treat our patients with HER2 negative metastatic breast cancer that is in the setting of germline BRCA1 or 2 mutation. And there's pretty robust preclinical data that suggests combining a PARP inhibitor with a checkpoint inhibitor might help improve upon the patient population that's eligible for PARP inhibition beyond those that carry a germline mutation. Several postulated mechanisms have been proposed, perhaps by increasing neoantigen load, increasing PD-L1 expression, maybe having a PARP inhibitor on decreases the capability to repair damaged DNA, and that damaged DNA might induce some sort of local lymphocyte infiltration, some sort of innate immunity. So several mechanisms, and based on that, there are a couple of trials that looked at the combination. The MEDIOLA the first cohort of MEDIOLA looked at patients with germline BRCA1 or 2 mutation and combined a PARP inhibitor, olaparib, with durvalumab, and we've seen several presentations on that over a period of time. The last one, I think, was at San Antonio this year, and reported, and MEDIOLA included patients first line and beyond, and reported pretty impressive response rates, about 70%. When you looked at the first and second line patients, it was a little bit lower as you went further along, but we've seen that individually with both PARP inhibitors and checkpoint inhibitors, the further along you get metastatic timeline, the decrease the response rates. Again, this is a single arm study. I understand that they have an expansion cohort ongoing, but what would be needed would be a randomized trial.
Yeah, it is interesting. There was a randomized phase 3 trial called KeyLink 009, which is looking at patients in the first line triple negative setting, regardless of BRCA mutation or HRD, so not stratifying based on HRD. Patients receive gem-carbo pembro and then are randomized to either continue with that or to receive the olaparib and pembro as sort of a maintenance approach based on some of this idea that you might upregulate the immune response. Whether that will be changed based on the data from Keynote 355 remains to be seen. So it'll be interesting to understand that based on the when we finally see that data presented in a setting. I think another question that comes up is whether, how do you decide whether to start with the IO or a PARP inhibitor? So if you have a patient who has PD-L1 positive disease who has metastatic triple negative breast cancer, what do you choose? Claudine, what do you choose in that setting?
We're talking about non-mutation carriers, not patients who have germline.
No, a patient who has a BRCA mutation and has triple negative metastatic breast cancer and presents with PD-L1 positive disease.
I think it's a difficult choice. I don't think there's a right or wrong answer. I just had a patient like that a few months ago, and we had that discussion. So the ideal thing is to put them on a trial where they can get a PARP inhibitor and immunotherapy at a checkpoint inhibitor. That's available, at some sites, but not for all patients. I think given that the immunotherapy data that we have at hand is most impressive when it's done earlier on in line, and the PARP inhibitor therapy was often in patients who'd received more treatment or potentially allowed more than first line. Again, this is, in all of those settings, the benefit is greatest first line. So you really have to make an individual choice. I think that one might choose immunotherapy first line and then go to a PARP inhibitor. But the ideal thing in patients like this is to put them on a combination if you have that available. I don't know.
I think that, many people would choose an IO first for the survival part, but then of course you want to throw in the PARP inhibitor relatively quickly. So then that's a big challenge. So having these trials with the maintenance, I think, will be really helpful. Priyanka, you I know that, you're one of the leaders of the breast group for SWOG, and they did a PARP inhibitor trial in patients who have BRCA wild type disease, right? I don't know in what subpopulation, but maybe you could tell us a little bit about that and when we expect results.
So SWOG 1416 was a randomized trial that really focused on patients with BRCA wild-type disease to look at the efficacy of PARP inhibitor when added to a chemotherapy backbone that included platinum. And the focus of this trial was to look at the efficacy of PARP inhibitor in the patients with HRD. And HRD is defined using tissue biomarkers. So really to look at the patients who don't have germline BRCA mutation, but biologically have other changes that suggest that tumors are deficient in repair capabilities. It's a phase 2 trial, and it will be presented at ASCO, at virtual ASCO this year. So, but
Is
I
it one
think
of the oral presentations?
the immunotherapy, we have to first identify the patients who were BRCA wild type and are able to derive benefit from PARP inhibitor, and then add immunotherapy there.
Yes, for our audience, will that be one of the oral presentations?
Yes, it will be.
That's great. So we'll look forward to seeing that. I think congratulations. And indeed, I think that'll be a really interesting presentation to hear about. I think one we're all interested in.